By age 40, women lose 8% of our muscle mass per decade. And hormonal shifts are through the roof. Yes, they start changing how our bodies respond to food, to stress, to sleep. I have learned personally about my body. So, why are we still blaming ourselves? Why do we, at some points in our lives, feel as if we are broken? I'm not kidding. I have literally heard this from friends of mine who have said that they feel broken. However, when you see someone like Kimberly Cunningham, nurse practitioner, who has studied the woman's body for over 25 years, literally knows our body and is a woman. So there's that. I can tell you this from the conversation we're having today and from what I have learned over the course of the many years I've known her and now since have become a patient of hers, you are going to learn why you should wait before you join in on the trends, what's happening today. And frankly, I just learned there's a new GLP1 on the market. I know nothing about it, and I am on one. But she's going to share more about that and so much more. Today on this episode, health over 40, 50, 60 plus, what actually changes, what's the hype, and what's actually working. So I'm Barbara Brooks, house guest. I want to welcome you home to the House of Middlescence. This is where we have honest conversations about work, life, health, and everything in the middle that shifts in the second half. I really love this conversation we're having today in particular because, again, too often do we feel that we are broken. And often enough, we don't do anything about it because you know what? We're too busy caring about other people in our lives. So today we are talking about our bodies, how they work, and all the things that, frankly, your gynecologist may not know. Because, yes, wait until you hear from Kimberly the length of time that doctors are studying our bodies. So sit back, grab a cup of Joe, join the conversation, and let's get right into health over 40. So let's unpack a couple of things. Let's unpack what is biological, what is misunderstood, and what are the options out there for us today so that we can feel better outwardly and inwardly in our bodies and have that energy again. Because I have energy back. I didn't even know I was missing it because my butt was sitting on the couch for 10 years on weekends and not sleeping at night. By the way, in the middle of the night, people know I'll be texting your butt at 2:40 a.m., hoping it's not notifying you. But because I need to, I don't know, have a conversation because I can't sleep. So I want to introduce to you my girl, nurse practitioner, Kimberly Cunningham. Hello, Kimberly Wetherington Cunningham. Welcome to the show. And you have literally changed my life. And I've known you for over 20 years, but me becoming a patient of yours after you finally, you've been telling me many years that I needed to come in and see you and get the blood draws and all the things. And you have literally changed my life. And I'm going to try, because I have half lashes on today, not to tear up during this show today, because you literally have changed my lives. And I know several people that obviously you can't admit to because of HIPAA laws, but I know people that do see you that say the same exact thing. So you are a nurse practitioner. You are solely focused on women's health, but also you have a couple of NFL players in your portfolio too. So it's women's health, but it's adult health in general. But women's health and wellness is really your jam. And you work with navigating perimenopause, menopause, hormones, weight shifts, energy changes. Oh my gosh, modern health tools. Am I missing some things? please share and say hello and share a little bit more about who you are.
Well, hi. First of all, thanks for having me. I own Cunningham Clinic. It's a functional medicine practice here in Denver. It's about 70% women, about 30% men. We usually start with the ladies, and about 3 or 4 months later, the partner comes in and says, I'll have what she's having because I can't keep up with her anymore. So almost always it's the women first, and then the men quickly follow suit. But you mentioned gynecology and that abysmal statistic. It turns out only 30% of all OBGYN residency programs have perimenopause and postmenopause hormone education at all. So, it's just baffling because 100% of their patients, if they live long enough, will need this care.
Well, yeah, because they're gynecologists, they're gyno. It's us, it's females. And Kimberly,
but there's more.
Yes, please.
And the 30% that have any kind of pre, peri, and postmenopausal hormone care, the grand total is 12 hours. That's
12 hours of study?
Total. In all of the years it took them to get board certified, when they come to the class that I teach, it's a 2-day, so it's 1-day lecture, 1-day clinical, because there's some procedures if you choose that form of hormone replacement therapy. They already have double what the OBGYN board certified providers have. And they're babies. Wow. They don't even know anything yet. They've just gotten started. Yeah. So when your OBGYN says you can't do hormones, first of all, they don't even know sometimes what all the hormones are, and that testosterone is really important for women. And then they don't know how to dose it. They don't know how the delivery options are. And they don't know how to make sure you don't overdose it, because you can be side effects if you get too much. So it's tricky to navigate.
What's interesting, Kimberly, is when you say they don't know how to diagnose it, so they, in a sense, poo-poo it, they yuck my yum. In essence, I just heard that term, because my yum is to have a better healthy, a longer health span. And for me, my HRT, and I'm on pellets, so, I'm openly about this, has literally changed my life. And for my PA, who I love and adore, to try to poo-poo it and say, talk about cancer, talk about all these things, I said, stop right there. You will never talk me out of having my HRT and getting this prescribed to me, because it's changed my life. And so it's interesting you say that, because it does happen. I've had other people I know that have said the same thing, that their gynos or nurse practitioners have poo-pooed it simply because they don't know the information, is what I'm assuming, right?
Correct. And there was a study in the early 2000s called the Women's Health Initiative that said, oh no, don't give women hormones because it's going to cause breast cancer. And that's been completely debunked. Unfortunately, not everybody keeps up and reads. And so they might be quoting completely debunked statistics. So in that study, they gave women just either estrogen or estrogen with a progesterone if they still had a uterus for postmenopausal women. Here's what's interesting. The arm of the study that showed this uptick of breast cancer, those women didn't start their hormone replacement therapy until they were 60. It is the absence of estrogen for more than 10 years that increases your risk of breast cancer. So if you look at that group, yes, they had more breast cancer than their younger peers, but they had less breast cancer than their same aged non-HRT peers. So even if you start late, HRT is breast protective. So hormones are heart disease protective, breast cancer protective, brain protective. Heart disease is the #1 killer of women. Mm-hmm. And that ApoB, or the glue that sticks the LDL to the vascular wall, goes up directly inversely to your estrogen falling. That is why 1 in 3 women have heart disease after menopause, but it's only 1 in 10 before. So it's the it's the estrogen piece. So it matters that women need their hormones. Also, without estrogen, women between age 50 and 60 can lose up to 27% of their computational cognitive capacity. So you lose math right at the time when you're supposed to be in the C-suites, right at the time when you're supposed to be the owner, the CEO, the leader.
Yes.
Hormones, you're actually losing brain function that may or may not be recoverable later. So that this matters. So we need to have better supports, which is why I teach. I teach for 2 universities and I teach for a medical company. So I want to get everybody good at this.
Well, and that's what's important. Why it's important to see someone like you, frankly, is because you're studying it and teaching it at the university level. So tell me, what actually shifts hormonally and metabolically inside of our bodies after 40, 50, 60 plus? What is happening to our bodies?
So it actually starts a little sooner. The loss of muscle mass you start seeing in the 40s, but the reason happened around age 35. So the average age of menopause in the United States is 50, and we know that testosterone production from the ovaries falls 15 years before menopause. And without testosterone, you have no muscle mass. And so we're losing muscle mass as that testosterone falls. So first of all, you lose your testosterone. So that's poor muscle tone, poor blood pressure control, poor lipid control, increased risk of inflammation, certain solid tumor cancers. And then with menopause, that's when estrogen drops off. And that is dry, wrinkled skin, vaginal dryness, hot flashes, brain fog. So all the things. So it starts around age 35 with testosterone. And then in that perimenopausal window, that's about 5 to 7 years before you stop ovulating. It's this whack-a-mole period of hormones where the estrogen is sky high, which is weight gaining and pre-diabetic. And then it's bottoms out to 0, which is moodiness and hot flashes. And then it's sky high again, and there goes your weight. And so it's this yo-yo that is really difficult to navigate, as well as that estrogen yo-yo. Some women, that's the seeds of endometrial cancer later, because the endometrium of the uterus isn't well organized. So we definitely want to manage that period, not just so you feel good and not have all these irregular bleeding episodes and mood swings, but also to protect you from endometrial cancer later. So those are the things that are happening. Yeah. Now, with that estrogen dominance, you see this in families where the women are sort of fine, they hit perimenopause and they go boom, and there's like 20, 30 pounds. And then it's really hard to get off. That's because their perimenopause is a stage of estrogen dominance, which is a weight gaining pre-diabetic mode. So we definitely want to stay on top of that as well.
Okay, so we're talking about estrogen. Mm-hmm. We haven't mentioned testosterone, which is something that I myself was lacking in after I took my 5-page lab results from you. I'm exaggerating, but I think it was like 3 pages.
4.
4, yeah. Can you tell us, so stress, sleep, muscle loss, all of those things are quietly changing our game. And we don't recognize, I think, because we're so, as women, used to caring for so many other people, that we start to avoid what's happening in our lives. And we also don't even, because we are not you, we don't understand that we can actually change our own game by getting on something like an HRT, a hormone replacement therapy, which of course is what I'm on with pellets. And I know there's pills and all the other things. Why is it for you? Why do you think it's important for us? And when is the time for us to recognize it's time to see someone like you who fully understands a woman's body, and that HRT may be the solution to our problems?
So I encourage starting with a functional medicine, either certified or focused practice, because that is looking at when we age, things start to fall apart underneath us. They weren't falling apart when we were younger. So what changed, and can we change it back? And that's the crux of functional medicine. So like I said, 4 labs is actually 4 pages is 5 pages now of labs. There's some more. I want to measure, and I recommend starting at age 35. I will check sooner if someone is symptomatic, and symptomatic of low testosterone is chronic inflammation, pain, loose joints, no muscle mass. You're working out, you're getting nothing for it, and you should. That's an indication of not enough testosterone. No libido is an indication of no testosterone. So I'll check sooner, but typically age 35. And then I love it when the labs are normal. That's great. I'll see you in a year. And then a year. But as things start to fall, like if your vitamin D is falling, if your blood sugar, if that hemoglobin A1C is going up, that tells me we've got some dysbiosis and some metabolic issues we have to address. It's so much easier to prevent a problem than to have to fix it later once it becomes a big issue. So I like to check early, but patients come in at any age. My oldest, newest to me patient was 82 when she came in the door on the walker that now she carries because she doesn't need it anymore. So yes, and she won't let it go. I keep telling her she doesn't need it, and she says, "Don't talk about my walker," but she carries it.
Yeah. And we're talking your oldest patient who is on HRT, correct?
Yes.
So tell us.
Okay.
What does HRT do for our bodies? And then we're going to jump into GLP-1s. But why do you feel, I mean, I think there's a misnomer out there that if you are going on hormone replacement therapy, you certainly shouldn't do it after a certain age. And a lot of people would say in the past, I guess, over 60, which to me is so young. I mean, I turned 60 in October. You shouldn't go on an HRT because of, this, that, and the other. But that's incorrect, right?
It is incorrect. So you'll stay on hormones until you don't want to live in a body that functions. Because without hormones, you have no muscle tone. You have all of these issues like heart disease and Alzheimer's and diabetes. And so all of these things start going wrong without your hormones. And so when you're ready for that to be your lived experience, you can stop them. I, for one, will never be off my hormone replacement therapy because I am living in a body that is hormonally age 30 to 35. And so hormone replacement therapy can be accomplished through lots of different modalities. There's creams, there's shots, there's patches, there's pills, there's pellets. There's different ways to replace the hormone in the human body. But the goal is to get you not to be a bodybuilder, not to be, super physiologic or these crazy levels. The goal is to get you to be a 30-year-old version of yourself. And then whatever was available for you at age 30 should become available again. That's the goal.
And when you say that, I mean, for me as a pro ager, you're talking internally.
On the inside.
The way your body is functioning is what you're speaking of. So why feeling stuck in a system? Why do you think? Well, okay, no, let's go back really quick and then we'll tap into the GLP-1s.
Sure.
You mentioned all the modalities. Is one better than the other on hormone replacement therapy?
The one that works for you and that you'll continue is the right one. So the right medicine is the one you'll take. Right. But I personally like pellets because it's endocrine mimicry. So solid organs like ovaries or in men testes, the solid organ has a blood supply that goes past, picks up the hormone, delivers it downstream, and causes an action like building muscles or getting nerve endings to the clitoris for good orgasm. So all the things we want the hormone to do, it has to be picked up and then dropped off. And so pellets sit in the subcutaneous fat. It's really easy. You just get them 3 times a year. And they have a blood supply all the time. And then anytime you get your heart rate up, you get more hormone. So when you're younger and you exercise, you need more testosterone to build the muscle that night when you're sleeping. So muscles are built overnight with protein on board and testosterone. So you need the testosterone to spike after a big workout. That's also, by the way, how a younger person can treat anxiety and depression with exercise. They're giving themselves a boost of testosterone because they got their blood flow up. So I like a system that gives you back as close to what your body did when you were younger. So I like a responsive system, but we can do creams, we can do shots, there's all different delivery methods. Most of my patients pick pellets because it's 3 5-minute procedures a year and you're good. Otherwise, it's 3 times a week shots, twice a day creams, twice a week patches. It's a lot. Women don't need more work.
We certainly don't, Kimberly. And I like my pellets. I like coming in and getting that little tic tac, underneath the skin there, and I'm in and out, as you said, within 5 minutes. It's pretty easy
for me as well. But yeah, I have all of the modalities available, but most of especially the women, they're all on pellets.
Yeah, I appreciate the pellets. Okay. Let's talk about GLP-1s because before we started the conversation, you alluded to the fact that there could be a new GLP-1 out there. And, as I've said a million times before, here and everywhere in between, to anybody I can, my weight loss of just over 58 pounds, started February 7th of 2024, and I remain on a GLP-1 because my labs said to you that obesity runs in the family, and obesity is a disease, which a lot of folks forget and or don't recognize, right? So I will always be on my GLP-1, and I thank you for one for encouraging me to do something, and GLP-1 was, the outcome, my solution. Talk about what GLP medications are out there today and what they are not, and let's talk about the muscle mass, and all those things as well. So let's talk GLP-1s. What's out there now? And tell us about this new GLP-1 that I haven't heard about, and probably no one has.
There's currently 2 on the market in the United States. There is semaglutide, brand name Ozempic, and then you've got tirzepatide, brand name Mounjaro or Zepbound. So semaglutide is the earliest one. It's just GLP, glucagon-like peptide. It just has one peptide responsible for helping clear sugar. It's clunky. There's a lot of GI upset, so acid reflux, constipation, projectile vomiting. This is not better. And so tirzepatide came out. That's Mounjaro, much more elegant. It's got GLP and GIP, so we just don't really see side effects with it. We see much better weight management with it at lower doses. We see a lot better longevity so these are considered geroprotective. You talked about having a better health span. So there's health span, there's lifespan, there's how long you live, but then how well do you live when you're alive? And so we want our health span to equal our lifespan. And so tirzepatide is showing better geroprotective, whereas you can live longer and live better than the semaglutide. But there's a third one coming, which is called retatrutide. It is not on the market commercially yet in the United States. It should launch any day, but you can get it compounded. And what it is GLP and GIP. So it's tirzepatide plus glucagon. Now, glucagon is normally made in the liver. It is a hormone that tells your body, use fat for energy. So when we're bringing down the blood sugar and we are correcting for metabolic dysbiosis, which helps eliminate visceral fat and LDL and help with a few other things in the body, if we add glucagon to the GLP and GIP, now you're burning fat a lot more. And so for people who have greater than 50 pounds to lose, for people for whom the GLP-1s are traditionally, so tirzepatide or semaglutide, haven't worked, this is looking like it will be a really great solution. Now we have to go very slowly on this one, because when you're cutting fat that quickly, which everybody's like, yeah, let me get the fat off my belly or wherever you're holding it, we want to be careful how much we're pushing through the liver, because you can sediment some of that fat down into gallstones, and emergency gallbladder surgery is not better. So we want to go very slowly and carefully. So for those of us who will be prescribing this, who have it, we'll just go very slowly and carefully so that we don't need to ratchet up all the time. And we also found out with the other ones, if we just gave it more time, we still got there and we didn't have side effects. So that one commercially, soon, it will be very expensive commercially. Compounded, not as expensive.
And let's make it clear, when we are going to you and to clinics, you're the Cunningham clinic, we are on a compound, because I think people also, they're getting it online and it's not working because they're getting it, who knows from where. They're getting it from different pharmacies, from different this. So can you educate us really briefly on where to truly get the right form of this prescription? And what's different?
So brand name prescriptions in the United States are protected by patent. They are within 3%, pill to pill, shot to shot, whatever the it is, it's within 3% if it's a brand name, up to 5%. Generics, when they become available, are 30% swing, so that's why they're not as good. But for brand name medications, that exact strength or milligrams per milliliter of fluid or whatever the it is protected by patent. If a patient needs a different concentration and it is medically necessary for them to be on a different concentration, that is allowed to be compounded by 503A pharmacies. And those are 503A is they'll make a medication just for you. They're also able to be compounded by 503B pharmacies, and that's going to be like a big stock bottle of Botox or a big bottle of something that your doctor is going to administer at the clinic. And those are 503B formulations. And so both are state and federally regulated. These are, if you have a compounded tirzepatide at a clinic from a 503B pharmacy, that is going to be federally inspected, and that is pure tirzepatide. So there isn't anything untoward about it. Now, I don't know what online people are doing or how they're getting it.
That scares me when people say, we have a mutual friend who, well, actually, I don't know if you know this person, who
I wouldn't be able to tell you.
who had tried, several of these by going through an online pharmacy, and nothing's worked. I'm like, girl, that's because you're not getting a real drug. You don't know what you're putting in your body.
Well, and then there have been pill formulations of both semaglutide and tirzepatide for a few years now, and they just don't work very well. It winds up not being very cost effective because you get so much medication in the pill that now you have to take all these other medications for the constipation and the nausea. At what point should you just do the shot of a clean formulation and you'll be fine?
Well, I again can't help but thank you. And I do want to, one of the things, as we come to a close, one of the things that prevented me at the beginning from wanting to do the GLP-1, even before I was talking to you about it, is I thought it was cheating. I also thought, I'm taking money from the mouths of babes, literally from people that were diabetic, because there was that time when it was purely, and you correct me if I'm wrong, for patients of diabetic. Well, I'm pre-diabetic, or no longer pre-diabetic, because of you. But all these things were going through my head, and I had going through my head, and I feel like these, the feeling of it's a support tool. I think what happens is we think it's cheating by taking this drug, when in actuality, it's a support tool. Or how would you express that this is not cheating? If you have health issues like mine with obesity and all the things, it's not cheating. At least it's literally taking care of your body. I guess that's what I'm trying to say.
So first of all, if somebody has high blood pressure, you're going to put them on a medication for high blood pressure. If somebody has a diagnosed medical condition that needs a medical intervention, they go on the medication. Pre-diabetes is pre-Alzheimer's. It's not something to watch. It is something to treat. If your hemoglobin A1C is above 5.5, you are marching down the Alzheimer's road. And we've got to get that dialed back. And so when you're looking at someone who is pre-diabetic, who cannot get the weight off, and you're reaching for a medication to treat that, that's in no way cheating. Here's the other thing. GLP and GIP are made in the small intestine. Insulin is made in the pancreas. They're just different peptides responsible for sugar metabolism in the body. We know of another one. It's called octodecanoeuropeptide. It's from the glial cells in the brain. But these are things that are missing in men and women, particularly women with very low sex hormone binding globulin. There was a study out of Switzerland or Sweden, I can't remember which one, it was about 13 months ago now, showing that with a low sex hormone binding globulin, they do not make GLP and GIP. It's just like type 2 diabetes. It just doesn't have a name yet. So we're throwing it in the bucket with that. But what that means is, for women whose SHBG is very, very low and who are struggling with weight, first of all, they needed this medication probably since they hit puberty. They've been probably fighting the same 20, 30, 40, 50 pounds since they hit puberty. And they'll need to stay on one of these medications, just like a diabetic will need to stay on their medication. So we don't have a name for this peptide deficiency yet, but you can't journal your way out of not having insulin. And you can't journal your way out of not having GLP and GIP in your body. You can't. You can't exercise your way out of diabetes, type 1 diabetes. You can't. It's very difficult to exercise your way out of type 2 diabetes, probably because it's not just insulin resistance that's the problem. It's a deficiency of these other two peptides.
Got it.
Yeah, it's not cheating. It's good medicine.
Okay.
Yeah.
I love it. Thank you for that. And I want to say thank you for everything and for joining me today. And to culminate what we're saying, we're really saying health after 40 is not really about shrinking who we are or not foregoing how we are feeling or evading how we're feeling. It's really about understanding how our body works, right, Kimberly? And choosing the support that actually fits in what I want to say is my season of this time in life. And for me, it's season 59 because I'm 59. And that it's really not too late to take care of our bodies, as you just said, as this 82 years young woman decided.
You know, we spend so much time taking care of our families and our children and our spouses and our communities, and it is okay to take time to support the only house you get to live in, which is your body, and making sure that it's going to carry you all the way. And so going and getting the right labs and making sure that you've got the right support and the right components supporting your body means you get to go live in a body that works for as long as you want. So that's important to see somebody who can get those labs and really know how to read them.
Yes, I love that. So thank you so much. I want to thank everyone for joining us today on the House of Middlescence. Where can they find you, Kimberly, if they live in Denver? But also you help people around the globe. So please give the information on where they can find you.
So CunninghamClinic.com is the clinic's website. We do take telehealth patients. And we have a whole functional wellness program at my clinic. And the website will give you all the information that you need to get started.
Yes, CunninghamClinic.com. I love it. Thank you. And thank you all for joining me today. Please join me next Thursday morning at 8 a.m. Mountain Time for a live or recorded. It really depends on the topic. And thank you for joining us today, and have a great day. Remember, aging is a privilege. And so whatever age you sit at, you woke up today, your eyes are open, you joined us today, and you are alive. So make it a great day, everyone.